All right, so I think now we can get started. All right, so good morning again, everyone. Thank you so much for joining us today for our GI Division Grand Rounds. It's my true pleasure to introduce Dr. Bryson Katona for today's talk. So Bryson is the Jeffrey and Cynthia King Assistant Professor of the GI Division at University of Pennsylvania Pullman School of Medicine. He currently serves as the director of the GI Cancer Genetics Program and the director of also the Lynch Syndrome Program at UPenn. He's a physician scientist who is an expert in GI cancer genetics, and his research program spans the basic, translational, and clinical spectrum of hereditary GI cancer syndromes. Bryson currently oversees clinical pancreatic cancer early detection efforts at UPenn, where he serves as the site PI for both the CAPS-5 and PRECEDE studies. Bryson is currently the past president of the Collaborative Group of the Americas on Inherited GI Cancers, also known as CGA-IGC, and I had a pleasure of closely working with Bryson on the Executive Council of CGA this past year. He has published extensively and also the current chair of the publication committee for the Pancreatic Cancer PRECEDE Consortium. So without further ado, Bryson, thank you again so much for joining us today, and I'm really excited and looking forward to your talk, and the floor is all yours when you are ready.
Well, thanks so much for the introduction, Appy, and the invitation to talk. I've known Appy for years, as we both do all the hereditary GI syndromes. So it's a real pleasure to come and talk today. So today I'll be talking about pancreatic cancer screening and a lot of the controversies in the field, and hopefully we'll have the time to highlight a lot of our recent work in this area. A lot of people that don't do pancreatic cancer screening may think it's a fairly simple and straightforward process, but there is a lot more controversy than many people realize. So these are my disclosures right there. So just to, before I get into the meat of the talk, our research group really focuses on all things hereditary GI cancer related. I do only see patients in this area, but I also have a clinical research group and a basic science laboratory as well. And so outside of the pancreas, we do a lot of work in hereditary gastric cancer, including hereditary diffuse gastric cancer syndrome and BRCA and Lynch syndrome associated gastric cancer. And then we also do a lot in polyposis syndromes and colorectal cancer. And we try to really combine early phase clinical studies with cell culture and organoid models, as well as mouse models of these hereditary diseases. So just throw that out there because we love to collaborate and have a lot of good samples and biobanking that we'd love to share if anybody is interested in these areas. So what I'd like to do today is talk a little bit first about pancreatic cancer risk, and then try to address three really important questions in the pancreatic cancer screening field, including who are the high-risk individuals on whom we should be doing screening on, how should we actually be doing pancreatic cancer screening, and does all this screening that we're doing actually work? So let's first talk about pancreatic cancer risk. So as you all know, pancreatic cancer is not one of the most common cancers, although it is creeping up into the top 10 for both men and women in terms of most common cancers diagnosed. And of course, we know that it's one of the most deadly cancers. When we think of lifetime risk of pancreatic cancer, typically what we quote people is about 1 to 1.5% lifetime risk. And of course, this is in the average risk population. Looking across all pancreatic cancers, the vast majority are considered sporadic, but we do think about 10% of pancreatic cancers are due to some familial risk, either due to a known inherited predisposition syndrome or some other familial risk, possibly through shared exposures or genetic etiologies that we just can't identify at this point yet. Thinking about what that risk is, that risk goes into kind of two buckets where we just have risk based on family history, where that risk is really proportional to the strength of the family history. And so, a lot of times we'll see patients who have 2 or 3 or 4 relatives in the family with a diagnosed pancreatic cancer, and so that risk certainly is proportional to the number of relatives who are affected in the family. But then we have a growing number of genes that are also associated with increased pancreatic cancer risk, and those can come in several different buckets, including breast cancer risk genes, including BRCA1 and BRCA2. ATM and PALB2 also fit into this category. We have the Lynch syndrome genes, which are associated with increased pancreatic cancer risk. And then we have some rarer syndromes, including CDKN2A carriers, Li-Fraumeni syndrome, and Poit-Jaeger syndrome, which are all associated with increased pancreatic cancer risk. And then finally, we have carriers of hereditary pancreatitis genes, where that risk is increased as well. And, when we think about family history or we think about genetic susceptibility, I think one of the difficult things is actually trying to really determine a true risk estimate for these individuals. Because a lot of the data that's collected on these individuals is done in a retrospective manner. And so I think to really properly inform patients about their risk and really counsel them about their risk, we really need high quality studies to help us properly define the risk in these high risk individuals. And so obviously prospective studies are best for this. And so one area that we were really interested in was working with BRCA1 and 2 carriers to really determine, what is their true pancreatic cancer risk, ideally in a prospective manner. So I had the opportunity over the last year or two to work with Stephen Narod, who is a real giant in the BRCA1 and 2 field from the Women's College Hospital in Canada. And he runs this group called the Hereditary Breast Cancer Clinical Study Group, which follows a very large cohort of women with BRCA1 or 2 mutations. So we published this work late in 2024, basically looking at the incidence of pancreatic cancer in women with a BRCA1 or BRCA2 mutation. Now, for this particular study, this again involved women from the Hereditary Breast Cancer Study Group, involving 66 centers in 12 different countries. These individuals, when they were enrolled, completed a baseline questionnaire, and then they would ideally complete annual follow-up questionnaires about changes to their health. It's a gigantic prospective cohort with over 8,000 women who were enrolled. Looking at this cohort again, over 8,000 women who were enrolled. The age of enrollment was in the late 40s, and most of these women had the average was about 9 years of follow-up. These were primarily BRCA1 carriers. However, there were almost 2,500 BRCA2 carriers who were involved in this cohort. And the majority of these patients did have a history of breast cancer, which was not exclusionary for the purposes of this study, as that would take out too many eligible individuals. A very small percentage, only 1.2%, had a first-degree relative with pancreatic cancer. And as far as distribution, these individuals were distributed primarily between Poland, the United States, and Canada. So in this cohort, there were actually, again, this is a prospective cohort. And so there were 34 pancreatic cancers that were identified, and these are incident pancreatic cancers. And so for those familiar with the pancreatic cancer early detection literature, having 34 incident pancreatic cancers in a cohort is like a huge number. Although if you think about it, this is 34 individuals out of over 8,000 who were followed. Importantly, the majority of these patients occurred after age 50, and only 2 of the 34 had a first-degree relative with pancreatic cancer. But given the size of this cohort, it allowed us to calculate to develop a very nice, what I think is at least a nice cumulative risk model here. And what you can see here for BRCA2 carriers, that cumulative risk of pancreatic cancer up to age 80 was about 2.7%, and for BRCA2 carriers, it was about 2.2%. And that risk really doesn't start to increase until after age 55 here. Now, importantly, cumulative risks are important, but I think when counseling patients, having an annual incidence rate, I think, is actually even more helpful. And so we were able to calculate annual incidence rates of pancreatic cancer for BRCA1 and BRCA2 carriers. And so what this comes down to is that For the BRCA1 carriers, their annual rate of developing pancreatic cancer was about 1 in 3,000 in this study. And for BRCA2 carriers, it was about 1 in 1,000. So, that's probably lower than a lot of people expected. And for me, this has been very important and helpful for newly diagnosed BRCA1 and 2 carriers. Because say you diagnose a, um, a woman in her 50s with a BRCA1 mutation. A lot of times these patients come in and they're very worried about their pancreatic cancer risk, almost more so than the breast and ovarian cancer risk. But you can tell them that, okay, your risk of pancreatic cancer over the next year is 1 in 3,000. And so it's much more important that you go deal with the breast and ovarian cancer risk first before worrying too much about the pancreatic cancer risk. So I hope that these numbers will be helpful for counseling women with a BRCA1 and 2 mutation moving forward. We did find a few associations associated with increased pancreatic cancer risk. So BRCA2 carriers did have a significantly elevated risk compared to BRCA1 carriers, which is what we would expect. Heavy alcohol users also had an increased risk. And it was found that individuals with the first-degree relative with pancreatic cancer had a significantly increased risk of pancreatic cancer as well. Although the majority of individuals who developed pancreatic cancer did not have a family history. Diabetes was also found to be a risk factor. So I think from this study, this is the largest prospective study to date of pancreatic cancer incidence in BRCA1 and 2 carrying women. We calculated these cumulative incidence rates for pancreatic cancer and then annual incidence rates as well, which I hope will be important for counseling these carriers. I think it's important to note that these carriers rarely develop pancreatic cancer before age 50, and there are certainly risk factors. So, heavy alcohol use, history of diabetes, and a first-degree relative with pancreatic cancer. However, the vast majority of BRCA1 and 2 carriers who develop pancreatic cancer didn't actually have a family history. And so I think studies like this, from my perspective, I think were very helpful and important for crystallizing the true risk of pancreatic cancer in these carriers. We certainly need more studies like this in some of the other high-risk groups, especially Lynch syndrome. And so that's an area where the field needs to kind of move in the years to come. All right, so let's try to start in answering some of these tough questions. So who are the high-risk individuals who should undergo pancreatic cancer screening? And so let's think about pancreatic cancer screening in general. And so for pancreatic cancer screening to work, what should it do? Well, one, it should improve survival from cancer. Certainly, we don't want to harm people. It should be a test that has high sensitivity and specificity. Ideally, we want to catch these lesions at earlier, more treatable time points. And, in the ideal world, it would also be cost effective. And so for any screening test, apart from pancreatic cancer screening, to meet all these criteria, it's actually a fairly high bar that it has to reach. And because of that, the U.S. Preventative Services Task Force has come out very strongly against screening asymptomatic average risk adults for pancreatic cancer. Now, of course, we're thinking about more high-risk populations, and there are several different guidelines that are out there, including from the NCCN, the CAPS Consortium, the ACG, the ASGE, and the AGA has some out there as well. So there are many, many different guidelines that are out there. All these guidelines differ slightly, but I'll try to kind of summarize, what they together, kind of what they say, and I think how most people in the field synthesized all of that data. And so when you think about those groups that should undergo pancreatic cancer screening, they can come in several different buckets. The first are these very high-risk syndromes where there's really not much debate in the guidelines, and these high-risk syndromes don't require there to be any family history of pancreatic cancer to be eligible for screening. So individuals with Poit-Jaeger syndrome, individuals with a CDKN2A mutation, and those with hereditary pancreatitis who have a clinical pancreatitis phenotype should really all be screened. And these are early ages, starting between age 30 to 40, and they should be screened regardless of whether or not there's a family history of pancreatic cancer in the family. Now, those are the ones that I'd say that are not controversial. The two that are a little bit more controversial are using criteria for familial pancreatic cancer. And so this is where you have a strong family history of pancreatic cancer in the family, but no detectable germline mutation. Typically, this is defined as having two relatives in the family with pancreatic cancer, and those relatives are directly related to one another, and then your patient is directly related to one of those relatives. And for families that meet familial pancreatic cancer criteria, typically we recommend screening starting at age 50. We also have all of our mutation carriers as well. For the mutation carriers, BRCA1 and 2, the other breast cancer genes, Li-Fraumeni syndrome and Lynch syndrome, the question about whether or not a family history of pancreatic cancer should be included as kind of a criteria for who meets screening eligibility is a topic of continued debate, and I'll go through that in a little bit more detail. But amongst these last two that have debate, let's tackle familial pancreatic cancer first. So going back to some of the older guidelines, such as guidelines from the International CAPS Consortium, and it's long been recommended that individuals that do have a strong family history of pancreatic cancer without a germline mutation should be eligible for screening. And typically that was defined as this middle criteria here, where there's, again, at least two affected relatives who are directly related to one another, and then your patient is directly related to them. So, for example, if your patient's father and paternal grandfather both had pancreatic cancer, that would qualify. Or a father and a sister had pancreatic cancer, that would qualify as well. And so many of us have been screening patients like this for years and years and years. Interestingly, though, when the NCCN came out with their pancreatic cancer screening guidelines many years ago, or not many years ago, several years ago, most people actually think that familial pancreatic cancer is formally recommended by the NCCN guidelines. Because when you look at the pancreatic cancer screening guidelines from the NCCN, this is a very busy slide, but I'll try to highlight what's important here, is that it does mention here familial pancreatic cancer in the NCCN guidelines, but it mentions it in the context saying that many pancreatic cancer screening studies have been conducted in these individuals with familial pancreatic cancer. However, if you look at what the NCCN recommends, or who they recommend should undergo pancreatic cancer screening, those with familial pancreatic cancer don't actually make the list. So this has been a point of frustration for me for several years, and I submit my comments every year that it should be added. So hopefully in the future, familial pancreatic cancer will get added to this table of recommendations. I think most people in the field, would screen individuals that met familial pancreatic cancer criteria, but I think at some point, insurance companies, may catch on that it's not in the NCCN guidelines, and I do worry about subsequent reimbursement. Now, I think probably the more controversial area is these gene mutation carriers and whether or not you should be including whether or not these individuals should have a family history of pancreatic cancer if to kind of make them eligible for pancreatic cancer screening. And so back in 4 or 5 years ago, back in 2021, things were a lot more simple then, and the answer was pretty straightforward. And back in 2021, really at that point, it was recommended that all of these individuals would only be eligible for pancreatic cancer screening if they had a family history of pancreatic cancer. And so that's in a first-degree relative or a second-degree relative. However, when you're using family history to determine whether or not somebody is eligible for a particular test, there are issues that can arise. And there are issues because family history is not perfect. Some people have very small family histories or small family sizes, so they may not have very many relatives who are at risk for a particular cancer. Other individuals have unknown family history, or maybe they have the wrong family history. They don't know what cancers their family members actually died from. And then in other cases, especially when you're talking about hereditary cancer risk syndromes, there may have been early deaths due to other cancers related to the syndrome. that again would decrease the amount of at-risk relatives. And then the majority of pancreatic cancers that develop in these mutation carriers as well actually occur in the absence of any family history of pancreatic cancer, like I had shown with the BRCA1 and 2 data. And so, I try to ask the provocative question, is it right to actually use family history as eligibility criteria for pancreatic cancer screening in these mutation carriers? And so, we had thought provocatively about this a long time ago here at Penn under the guidance of my mentor, Anil Rustagi, who was our division chief here and is now the cancer center director out at Columbia. And we had started a study back in 2015 looking at all BRCA1 and 2, ATM and PALB2 carriers without a family history and offering them pancreatic cancer screening. So people thought we were totally nuts at the time because all the guidelines recommended having a family history. We had published some preliminary results from this study several years ago. But basically what we had found was that the results, what we were seeing upon screening these individuals without a family history was basically identical to what was being seen through screening individuals with a family history. So we really were trying to make the argument that using family history to determine who gets screened for pancreatic cancer amongst these high-risk individuals, may not be ideal. And fortunately, the year after this particular paper was published, ASGE came out with their own guidelines that really kind of shook the whole field up, where they came out recommending that, in fact, family history should not be used to determine who's eligible, at least for BRCA1 and 2 carriers, as well as PALB2 carriers. However, they did still say that for ATM carriers and for individuals with Lynch syndrome, that you should still require a family history to recommend pancreatic cancer screening. So this was, kind of a big movement, seismic shift in the field, and I think brought a lot more people in for pancreatic cancer screening who had previously not been. Now, this would be nice if then all other guidelines kind of followed suit and recommended similar things. Of course, the NCCN came out with their recommendations last year, which was a little bit different to add more uncertainty to the field. And so the NCCN changed their recommendations this past year to recommend that all BRCA2 carriers and ATM carriers, that they do not need a family history, but for BRCA1 and PALB2, they do still need a family history. So it's quite confusing. I think this really confuses patients, certainly confuses providers, and I don't think insurance companies know what the heck to do now. But basically, for any of these breast cancer risk genes, you now at least can make some case based on one of these two guidelines that individuals can consider pancreatic cancer screening independent of family history. So with all these changes in guidelines that we were seeing, we were very interested to see what are pancreatic cancer screening programs, across the country and the world actually doing. And so we did a survey through the PROCEED Consortium, which I know UCSF is a part of. And this was an effort that I worked on very closely with an internal medicine resident here at Penn, Anjali Manam. I put her picture up there because she's applying for fellowships, and I think she does like the West Coast. She's absolutely fantastic. So if you guys have the opportunity to meet her, she's a real star. But what we did in this particular survey, and we just presented these results at DDW a couple weeks ago, was that we surveyed the 67 institutions that are part of PROCEED, including 37 that are US-based. For those that aren't familiar with PROCEED, the enrollment in this consortium started in May of 2020, and there's over 8,000 patients who are now enrolled, and we've been a very heavy enroller here at Penn. And I know, of course, UCSF is enrolling as well. For this survey, we invited all the different sites. We got an astounding 95% response rate from a survey, although we were quite annoying and pestering with our emails, but we thought that was pretty good. And basically, we let each site PI complete the survey. And so each site was only able to submit one survey. And so it was really interesting to see how different people's practices are. So one of the questions that we asked was, who's offering pancreatic cancer screening to gene mutation carriers where there is no known family history of pancreatic cancer. And what you can see here is that for BRCA1, PALB2, and ATM, about a third of centers were offering surveillance or screening to these individuals, and about half of centers were offering screening to BRCA2 carriers without a family history. Very few centers were offering screening to Lynch patients without a family history. But this is quite striking, right? These are all like high volume pancreatic cancer screening centers, and there's just really marked differences in clinical practice. We also wanted to assess what age people were offering this screening to carriers without a family history. And for some reason, this graph isn't displaying correctly. I'm not sure what's going on with these points at the bottom. But in general, most people were offering surveillance starting at age 50, with a few offering surveillance starting either at age 40 or 45. So less uncertainty there. For those individuals who were using a family history of pancreatic cancer to justify offering screening, we asked how tightly were these individuals, how tightly did that history of pancreatic cancer have to kind of track with the gene mutation. And this is a busy slide, but basically about half of people that used a family history of pancreatic cancer said that pancreatic cancer had to be from the same side of the family as the BRCA2 or BRCA1 mutation. But interestingly, about 30% of people said that they would use a pancreatic cancer from any side of the family, even if it wasn't from the same side of the family as the gene mutation. And a very small percentage, 15%, said they would only use the pancreatic cancer if it came from the same side of the family as the gene and the person with the pancreatic cancer tested positive for the gene. And so I think what this shows is that, our practices are really all over the map here. And, even within this the same consortium, we're all doing different things. And so, that we have a lot of work to do to kind of all get on the same page. And I think it doesn't help that our guidelines are all over the place as well. All right, so let's move on to the second tough question here is how should we be performing pancreatic cancer screening? And so I think there's three important parts. First is enrolling patients in screening studies. Then we'll talk about what we should be doing from an imaging perspective and what we should be doing from a blood work perspective. So as far as the studies, the two big ones in the US are the CAPS-5 study, which is funded by the NCI and is we're in our ninth or 10th year now of enrolling patients. It's primarily East Coast centers who are involved in CAPS-5. And then, of course, the PROCEED consortium, which UCSF is a part of. Now, one issue with pancreatic cancer screening studies is that in the past, these studies have not done a very good job of enrolling, having a good diversity in their participant enrollment. And so we wanted to look at that within the PROCEED consortium, especially since this consortium was started fairly recently. And so we were hoping that because it was started recently, we may have the opportunity to enroll a more diverse participant population. And so with some good friends, including Kelsey Clutie at University of Nebraska, Amy Lucas at Mount Sinai, and Faye Castrinos at Columbia, we worked with the PROCEED consortium to look for any disparities in enrollment early on in the consortium. And this, I think, was pulled from data up through 2022. So I think this was actually before UCSF had formally joined on. And so we looked at basically the first 1,100 high-risk patients who were enrolled in the PROCEED consortium to see how we were doing from an enrollment diversity perspective. What we found was that in this consortium, we had a good mix of familial pancreatic cancer and those with hereditary risk genes. It was primarily US-based, and we had a good distribution of enrollment across the ages. But what you can see here is that even amongst our cohort that was more recently enrolling, we still have massive underrepresentation of certain populations. So men are highly underrepresented. Only about a third of the enrollees in the consortium were males. And you can also see here that despite this consortium enrolling, over the last several years, we still have very suboptimal racial and ethnic diversity within the cohort. So clearly, we have to do a better job at broadening enrollment and encouraging more patients from diverse backgrounds to enroll in these studies. Now, importantly, though, once people were enrolled in the study, regardless of race or ethnicity, or also based on biological sex, there was really no differences in individuals' willingness to participate in different parts of the study, like DNA collection and biosample collection. And so I think it's just a matter of opening that door and getting these individuals involved. And then once in, everybody was very, very eager to participate in all parts of this study. Now, in terms of imaging for pancreatic cancer screening, most of us in the field typically would recommend imaging be performed on a yearly basis, and this is typically performed with an MRI abdomen with IV contrast and an MRCP. Or an endoscopic ultrasound. CT scan CT abdomen pelvis is not sensitive enough, and there's somebody in New York City that swears by abdominal ultrasound, but I think that's a little hocus pocus, and I certainly wouldn't trust that. Now, I'm preaching to the choir about MRI and EUS. They certainly have their pros and cons. Two that I want to talk about include the incidental finding rate, and then also the different performance characteristics between solid lesion detection and cyst detection rates between MRI and EUS. But first, let's talk about incidental finding rate. So when you're sending somebody for pancreatic cancer screening, I think it's important to, really highlight to them that there's a very high rate of incidental findings that may be found. Everybody, when they get an image of their pancreas, everybody wants to have a perfectly beautiful normal pancreas, but in fact, about a third of people will not have a perfect pancreas. This was data from the PROCEED consortium that we had published last year that showed that amongst baseline imaging upon enrollment, about a third of individuals had some sort of pancreatic cyst that was identified. And most of these cysts are less than 1 centimeter, and so they're not really consequential. But it is important to kind of, get people's minds wrapped around the fact that they may actually have something that is found on their pancreas. Now, how about EUS versus MRI in terms of how they perform? There's been several studies that have looked at this. This is a good one from Europe, where they found that EUS was much better at detecting solid lesions of the pancreas, whereas MRI was much better at detecting cystic lesions of the pancreas. However, you will note that this improvement in cystic lesions seen with MRI is primarily driven by these sub-centimeter cysts, which most of us would question the clinical significance of. But I do think it's true that in experienced hands, EUS is better at detecting solid lesions of the pancreas. And we've had, multiple cases that have really reinforced this here at Penn. I'll give you one example. This is a 60-year-old BRCA2 carrier who had a family history of pancreatic cancer. He came in, he was getting screened, and then came in for an EUS, and there was a 1.6 centimeter solid mass in the pancreatic head that was seen. This was FNA was performed at the time and came back non-diagnostic. He'd also had several cysts in that area of the head as well. This patient then got an MRI, which looked totally normal. They said everything looked fine other than cysts. He then got a second opinion, got another MRI, which again, excuse me, sorry, I'm getting over a upper respiratory thing. He got another MRI, which looked totally normal again. We brought him back in for another EUS that again, our therapeutic endoscopist saw this head mass. However, cytology came back non-diagnostic as well. But seeing this twice, it really couldn't be unseen. And so the patient was actually sent for a Whipple without a positive cytology, and came back with a stage 1B pancreatic adenosquamous carcinoma. So this was a really good catch. He's doing very, very well. But the fact, it's a little bit scary that 2 successive MRIs could not see this cancer. And even after the cancer was diagnosed pathologically, we went back to the MRIs and reviewed them with the radiologist, and they just could not see it. So I think in experienced hands, EUS really is a better test. Now, how are people across the PROCEED consortium managing their imaging? In terms of index surveillance, when somebody comes in for pancreatic cancer screening, about 2/3 of centers are doing MRI first, whereas the remainder are primarily doing EUS first. We're an EUS first center here, but so there is a little bit variability in what people are doing first. Now, we then asked the question, well, after this initial imaging modality, are people then sticking with that modality, or are they repeating, or are they changing modalities? And about 2/3 of people do say that they change modality. So if you start out with an MRI one year, then do EUS the next year, and so on. And most people are waiting a year between when the first imaging study is done and the second imaging study. There's a few places that do the second imaging study 6 months after the first, and then a smaller subset that do both EUS and MRI at the very first touch when a patient comes in for pancreatic cancer screening. Now, looking at following patients long term, about 2/3 of centers typically will alternate MRI and EUS. There's a few centers that are doing MRI only, and most people are using a year interval. So at least there's a little bit more consistency amongst what people are doing in this space. All right, so let's move on to blood work. Currently, there are no tests that are blood tests that are currently recommended by current guidelines. But I want to talk a little bit about screening for diabetes, CA19-9, and some of these cancer early detection tests. Oops, sorry, there we go. Okay, so diabetes has been shown to be an early marker of pancreatic cancer, where you can see some abnormal signals up to 3 years prior to the diagnosis of a pancreatic cancer. And because of that, many of us in the field have been using yearly screen for diabetes in these high-risk individuals to possibly figure out which of those high-risk individuals that may need more intensive surveillance. Now, does this actually work? Well, we don't really have much data. There was one study that was published late last year from the Netherlands where they claimed that monitoring for glucose and diabetes does not contribute. However, when you look at their numbers, they only had 9 people develop PDAC and 4 that developed diabetes. So I think they're grossly underpowered. But we certainly use diabetes monitoring on an annual basis here at Penn. How about CA19-9? So if you look at CA19-9, the issue with CA19-9 is that looking over the course of a population and how CA19-9 is distributed, the issue is that some people will have a baseline elevated level of CA19-9 that is above the upper limit of normal, and this is just their baseline. And so if you have a high-risk individual with an elevated CA19-9, it scares the heck out of them, and it scares the heck out of providers as well. I think the other issue with CA19-9 is that about 5 to 10% of pancreatic cancers and 5 to 10% of people will not express any CA19-9 at all. They're just CA19-9 non-expressors. So there are some issues that are posed, when following CA19-9. Now, some work out of Johns Hopkins had basically had shown that by genotyping these 2 enzymes, FUT2 and FUT3, which are involved in CA19-9 biosynthesis, you can actually help stratify what an individual's baseline CA19-9 level should be. And so what you can see here is that if you have people who are FUT3 null, these are the CA19-9 non-expressors. They're not producing CA19-9. You probably shouldn't be following it in them. On the flip side, if you have people who don't express FUT2, these are the ones who are CA19-9 overexpressors. And so they may have the elevated levels of CA19-9 that are above the baseline, but these may be just their baseline levels. And excitingly, with this genotyping, we started to do this in collaboration with Johns Hopkins through the CAPS-5 study about a year ago, where now that all of our high-risk individuals who come in, who are participating in the CAPS-5 study, will have genotyping of these 2 enzymes, FUT2 and FUT3. This is a clinical test. They get a clinical report back, and it comes back like this, where they're given a class A through D, and then they're given basically a customized range of what their CA19-9 should be. So if we do their genotyping and they're non-expressors, we tell them, okay, we're not going to follow your CA19-9 because you don't produce it. However, if they come back with a class D and they're potentially predicted to have a high baseline level of CA19-9, this is really informative, because if you then check their CA19-9 and it comes back as 60, you don't have to freak out, and the patient doesn't have to freak out as well. So this has been a real game changer for me for using CA19-9. How about these early multi-cancer early detection tests? Everybody's heard a lot about the Gallery test. For this particular test, it's very good at detecting metastatic pancreatic cancer, not very good at detecting early stage pancreatic cancer. I don't think it has a role in high-risk individuals who are undergoing pancreatic cancer screening. I will tell a quick story about the IMRE PanCan-D test. For those who aren't familiar, this was the first commercially available blood-based test that was specifically designed for pancreatic cancer early detection. When it was designed to either give a positive, borderline, or negative result. Individuals who didn't express CA19-9 couldn't have the test performed, and this test was clinically available on the market for almost two years. This was originally validated in a study that we had worked on here at Penn with Immunovia. Had a pretty good sensitivity and specificity even for early stage PDAC. But once it went on to the clinical market, we wanted to see how it actually performed in real world practice. So I collaborated with my friend who lives on the less desirable side of Pennsylvania, Randy Brand at Pittsburgh. We published these results about 2 years ago. But for this particular study, this is once the test was clinically available, we convinced the company to allow us to run 100 of these tests for free on patients as normal clinical tests. And so we had high-risk individuals who were undergoing pancreatic cancer screening, and we would offer them this test about a month or two before they came in for their screening endoscopic ultrasound. The patients would get the test, and when they came in for their EUS, we would give them the test results, and then they'd go for their EUS. So we figured that would minimize any uncertainty, because if they came back positive, they were literally like 5 minutes away from getting their EUS. We also spiked in a couple positive controls as well, and the company was not aware of which samples were positive controls. So I'm going to skip just for time's sake. I'll get to the results here. But what we found with this real-world test is that of the 94 high-risk individuals, none of whom have pancreatic cancer, we had 1 positive and 7 borderline results. And of those individuals with pancreatic cancer, the test was able to pick up 4 of the 6 individuals. So looking at these results kind of based on the CA19-9 level, the bars here with the little asterisks are the pancreatic cancers. You can see the 2 pancreatic cancers that were missed had low CA19-9 levels. So clearly this test was really driven by the CA19-9 result. And when you look at the performance characteristics, it did not have real great positive predictive value or negative predictive value. And especially if you included these, this test would give a borderline result back, which, for many patients, if you get a borderline result, that might as well be a positive result, because that's going to worry people and scare people. And so if you consider borderline results positive results, the positive predictive value was very, very suboptimal. So, this was the first data from really real-world data from the first clinical commercial blood-based test for pancreatic cancer early detection. I think it showed that it had a robust negative predictive value, but the positive predictive value was really suboptimal. And I think it helped us learn a lot of lessons about what these tests really need to do in real-world practice. Now, based on these results, actually, the company ended up pulling the test off the market in the summer of 2023. They've been retweaking the algorithm, and should have a new test to launch later this year, which I think will have a lot better performance characteristics. The other clinical one that I'll just mention that actually is currently on the market is the Avantec test, and this is by a company called ClearNote. They had an initial validation study that was published 2 years ago. They showed decent sensitivity and specificity for pancreatic cancer. We don't have any prospective data published on this test yet, although it is 100% commercially available for patients to get if they want. I have personally not ordered this test, but this is what the test reports come back as. The test reports can come back saying that there was an abnormal epigenomic signature that was detected, or they'll come back saying an abnormal epigenomic signal was not detected. As I said, I haven't ordered this test. I've seen a couple patients who have come in with test reports. Those that come in with these negative test reports are actually quite perturbed that they paid $1,000, because if you read the text here, it says, the signal was not detected, but this does not exclude the presence of pancreatic cancer. And so patients are like, well, why the heck did I just pay $1,000 for this if you can't exclude pancreatic cancer? So I think we just need to see more prospective data on this particular study. So on the commercial-based blood tests, at this point, I would not recommend their regular use. I think, there's a lot of false positives. There's no insurance coverage for these. The data is still immature. I would love to see some of these companies do some true prospective studies on these tests moving forward. But we'll see. It's very easy to get these things apparently through FDA or through kind of the necessary approval to just offer them commercially. So what are people across PROCEED doing? Most people in PROCEED are using blood glucose or diabetes monitoring. Only about a third are using CA19-9 testing, and very few centers are actually using commercial early detection tests. Okay, in the last 2 or 3 minutes here, I'll just try to answer the question, does pancreatic cancer screening actually work? We're doing all this work, does it actually work? I think probably some of the best data that we have to date is data from our CAPS-5 study, which was published in JCO a couple years ago. This followed about 1,400 high-risk patients who were undergoing pancreatic cancer screening. And I'll just cut to the chase here and show that if you look at the pancreatic cancers detected during surveillance versus those outside of surveillance, those detected during surveillance had a substantially lower stage. There was a major downstaging of pancreatic cancer for those in surveillance. You look at survival times, and they're markedly improved in those who were detected during surveillance compared to outside of surveillance. And the European data doesn't necessarily agree with our data in the US, but I think as far as US data goes, this is the best that we've got so far and is encouraging for patients. We further went on to look at data from the CAPS-5 consortium and match this to patients in SEER. And again, showing that in high-risk individuals undergoing surveillance, there was a substantial downstaging of pancreatic cancers at the time of diagnosis, and a very extended improvement in overall survival. Now, of course, this does show that pancreatic cancer works, but it's important. Pancreatic cancer screening works, but it's important to know that, when you do screening, you still have to screen a lot of people to actually have an effect. And there's been 2 estimates on this about numbers needed to screen, and it's thought that somewhere between 100, you may need to screen up to 110 to 130 individuals to find one high-risk pancreatic lesion. So this is a lot of procedures. I mean, we follow, over 500 high-risk individuals, and, we have only a couple converters every year. And so you have to do a lot of screening for very few events. And so that, of course, brings up concerns about cost effectiveness. I won't go into the details here, but Louise Wang, who's a very talented early career faculty member at Yale, and I did a review of the cost effectiveness literature out there that was published last year. So if you're interested in diving into the cost effectiveness, all that information is in there. So last, I'll just leave you with a couple take-home points, is that I think pancreatic cancer screening should be considered in eligible individuals, but I do think you should discuss the risks, benefits, and limitations. If you're going to do pancreatic cancer screening, I would certainly do annual imaging. I would certainly screen for diabetes. And, I think I've been using now CA19-9 more frequently as long as I'm able to get the genotyping information. I don't think that multi-cancer early detection tests or single cancer early detection tests are ready for broad implementation yet. And then certainly, enrollment in clinical trials is really important. It's impossible to do anything in pancreatic cancer early detection as a single center now. We really need collaborative studies. I think the guidelines should try to harmonize and should probably provide more guidance as people's practices are still kind of all over the place. And certainly we need more research in many areas, especially trying to develop new blood tests. So lastly, if anybody's interested in hereditary GI cancers, I've worked very closely with API through the CGA for many years now. But come join us in St. Louis. It's 2.5 days of all hereditary GI cancers. And then I'd love to thank my group. I work with a great group of young individuals who really keep me motivated and energized. And of course, all my collaborators. I would need a whole nother slide, but I tried to highlight them as I went through the talk. Pancreatic cancer early detection, really requires collaboration and would be impossible to do without so much wonderful collegiality. So thank you so much for your attention and for the invitation, Appy. And I'd be happy to take any questions or comments.